My name is Norman Swan. I produce and present the Health Report on Radio National. Before we start, it's important to acknowledge and pay due respect to the traditional and original owners of the land on which we meet, and to elders past, and certainly those elders who are present. This is an important discussion to have at this 2014 conference of the International AIDS Society, and I'd just like to spend a moment in silence for those people who have not been able to make this conference through what effectively is a war crime. Thank you very much. And here's a little video teaser to give you a sense of what things were like when our story begins.
December 1981. Young, previously healthy Californian men die mysteriously from rare infections their bodies should have been able to fight off. No one knows why their immune systems failed. It was the first published account of what was to become known as AIDS. And from the beginning, it was clear that this epidemic had an extra dimension that would make it much more than a threat to public health. The victims were then all homosexual men.
Oh, well, it was obvious to us right from the start that AIDS was going to be an enormous both obviously an enormous medical problem, but also an enormous political problem.
We face, as I said at the very beginning, one of the most serious public health problems this country has faced since Federation.
So thank you, Norman. My name's Margaret Shield. I'm both the Acting Vice-Chancellor of the University of Melbourne and the Provost there, and it's my very great pleasure on behalf of the University to welcome you here today to this witness seminar. Can I add my acknowledgement of the traditional owners of the land and pay my respects to their elders past and present, and also add my acknowledgement of the sadness at this time of the events in the Ukraine and the passing of participants who were attending this conference, and also a Melbourne University alumnus and her partner on that plane as well. We participate today in a very important event. The idea behind the witness seminars is to help historians of medical science in particular document rapid changes that were occurring at that time. And it will focus on this period that we saw a taste of in that video of what Australia did in response, both in terms of communication and health policy in response to that crisis. It's a great pleasure for the University to bring together some of the most important participants of that time, Dr Neil Blewett, the Chair of the National AIDS Task Force, and I might add our former Vice-Chancellor, Professor David Pennington, and certainly as a student in Sydney at that time, that was the first time I became aware of David's many talents, and have subsequently had the benefit of that, both in terms of our own organisation, but in other initiatives that I've been involved in. So my role really is to welcome you all, to say how delighted we are to be here, and to introduce Norman, who needs no introduction. He was a young journalist at the time of the AIDS the AIDS crisis, and he's gone on to document many important events in medical science, both here and internationally subsequently, and I'm sure he will do an able job of introducing the rest of this session. Thank you, Norman.
Let me introduce our panel to you. On my far right, your far left, is Gino Vumbako, who established the first needle and syringe exchange program in Sydney, with Alex Wodak, who is also on the panel, and I'll get to Alex in a moment, and helped the New South Wales government, who were initially, I think, as you'll discover, a bit reluctant to move on the needle exchange program. Subterfuge is an undercurrent to this whole discussion of the early days of the HIV epidemic, and a lesson for policymakers today. Next to Gino is Judy Frecker, who's a nurse and was a nurse at Fairfield Infectious Disease Hospital from 1980, who treated HIV patients, AIDS patients throughout the 1990s, and still works in the area of sexual health for the Royal District Nursing Society. David Menadue was actually one of the first people in Australia to be diagnosed with HIV and became one of the first presidents of people living with AIDS in 1989 and is a long-standing advocate for people living with HIV. And that theme is another very strong theme of the early days of this epidemic, the transformation that occurred in doctor-patient power relationships. Transformed forever, at least in this area, and was a lesson to other parts of medical care. And David will no doubt talk about that, as will the others. Next to David is Professor Emeritus David Pennington, who Margaret has already referred to, who was chair of the National AIDS Task Force for 4 years, former Dean of the Faculty of Medicine and Vice-Chancellor of the University of Melbourne, a haematologist, and it was no accident that he came to the role in HIV/AIDS in those early days, and we'll come back to that later. And during the video display, I want you to guess at which point, if any, David had a haircut during all 4 of those years. Neil Blewett was Federal Minister for Health during this epidemic, at the beginning of this epidemic, and he and his staff, and we'll talk to, I think, at least one key member of his staff is in the audience, about how this was handled and became an example to the world about how to handle this epidemic, and we avoided some of the worst that was seen in many other countries. Next to Neil is Alex Wodak, who's Director of the Alcohol and Drug Service at St Vincent's Hospital, Sydney, former president of the International Harm Reduction Association, and was also involved in opening Australia's first needle exchange program in New South Wales, and also was heavily involved in the first medically supervised injecting centre in King's Cross in Sydney, which postdates this the time period that we're talking about, which is really about 1983 through to about 1990. And last and certainly not least is Adam Carr, who's a journalist and editor with gay news publications, founding member of Victorian AIDS Action Committee and president of the Victorian AIDS Council. Please welcome our panel. Judy, when was your first patient?
I think it was 1983. I kind of get mixed up with the years, but I certainly remember him very well. And he was a teacher who'd worked overseas, came back, had AIDS, was a very skinny, wasted man. And his only support was his sister, who looked like everybody's grandmother, and they couldn't tell anybody. They were ostracised.
Did you know he had AIDS, or was it recognisable as such?
We recognised it by then. We knew that he was what we call barrier nursed. We all wore gloves, masks. He had food on paper plates. The kitchen staff wouldn't go in there. It was there was some staff at the hospital that didn't look after him because they had children or were married, but that only lasted for a short time. And I think people at Fairfield just embraced this new infectious disease, that people were ostracised, and the community were, they couldn't tell anybody about it, they were dying. He actually survived long enough for the Victorian AIDS Council and the community support to help him go home and support his sister, and I think it made a big difference to him. Like, some other people died before all that sort of stuff came in, but yeah,
what sort of impact? What impact did that have on you? How transformative was that for you as a nurse?
I think it changed how there's a few of my colleagues here today, but I think it changed how we worked, because there was a bit of they were the same age as us. They were dying, they were young, they were ostracised because most of the people in the early days were gay, so they disengaged from families, and they were just very alone and very frightened and confronted with this awful thing that had, they'd have Kaposi's sarcoma, diarrhoea, unrelenting, and would try anything to survive. So they were trying pills that I'm sure eventually helped contribute to their death. But they were very courageous.
David Pennington, I mean, I can remember those days. There were the early reports in the New England Journal. People knew something was going on, but they hadn't a clue what. How much did it have an impact in the early days? I mean, was the medical community expecting it to hit Australia?
As far as we could read, it was a completely new disease that had come from nowhere, although later the association with Africa and so on emerged. But nonetheless, it was a disease of completely unknown origin, for which there was no treatment. The medical profession had virtually no knowledge except for a few immunologists that had been reading journals, and I can remember first being told about it when I attended a meeting of the National Blood Transfusion Executive in the first week of March of 2083. And in fact, there had been one case diagnosed at St Vincent's Hospital in December of the previous year, a visiting American.
And there'd been this unseemly competition to be the first to diagnose the first case.
Well, they took pride in the fact that they had diagnosed it, therefore they felt they should own the whole issue. But in fact, there was at this time clear evidence that it could be spread through blood transfusion and in treatment of haemophilia. And as I was chairing the Red Cross National Blood Transfusion Committee, we had to take this very quickly, very seriously, find out all we could about it from America.
Adam Carr, to what extent was the gay community ready for this? Because it had been well reported within the gay press and well reported in the medical press prior to 1983.
Well, not a great deal prior. There were articles began to appear in the press in 1982, fairly sensationalist ones about gay plagues and gay cancer, which we found very hard to believe that there could be such a thing as a specifically gay cancer. It wasn't until I began to research and write the first major article that I wrote in May 83 that I went and read the articles that had appeared in the medical press and realised that this was real and it was serious. Up to that point, I think there was a fair amount of scepticism that this could possibly be true. And of course, we didn't see people living with AIDS in Australia for a couple of years after that. So we were relying on what we were seeing in the United States. And fairly quickly in the course of 83, we began to realise that this was real, that it was, as far as we could tell, going to happen here, and that we needed to get prepared.
But the mode of transmission in the early days wasn't entirely clear. People said, "Oh, is it amyl nitrate? Is it?"
There were a number of conflicting theories about that. There was a theory that it was due to lifestyle factors such as drug use overwhelming people's immune systems. That was one theory. The other theory was that it was an infectious agent such as a virus. And once we began to see evidence that the disease was affecting people who had shared needles while using drugs, people with haemophilia, people who had received blood transfusions, the evidence that it was an infectious agent became, to my mind anyway, and I think to most people's, much clearer.
But people hadn't quite changed their behaviour at that point.
Well, people began to change their behaviour once we began to report what was happening in the gay press, and once it became clear that it was being spread sexually, yes, and that happened in the course of 1983.
Alex, you were involved in the first person diagnosed with HIV/AIDS, although you didn't know it was HIV in those days.
Yes, in association with David Cooper, who was a young man from New Zealand, and I remember going with David and explaining the diagnosis to him and telling him what the prognosis was, and then arranging for him to return to Napier in New Zealand. And unfortunately, although we kept it all quiet, the press in New Zealand got to hear about it, and poor guy had a terrible response from the media as soon as he arrived in New Zealand, and it was a really shattering, very emotionally draining experience.
What happened?
Well, the press surrounded his plane, and he was in New Zealand, and there was nationwide television and media saturation, and he was treated like leprosy times rabies in New Zealand. And
did he get medical care there? I mean, what happened to him?
Then we'd arranged of course we'd made arrangements for a hospital to take him on, and he was already very ill, and he was taken care of somehow, but that was really a savage lesson in just how brutal the media aspects of this were going to be.
Neil Blewett, set the context for us politically at that time. You had just come into power in 1983, the Hawke government. You were trying to get the Medicare bill through. You had a riot with the AMA. In fact, David Pennington had helped you out, I think, with a private practice inquiry around about that time.
Well, really before that, we did come to power in March 1983 with a very broad health agenda. There was the reintroduction of Medicare. There was the pharmaceutical benefits scheme, which we were making major changes to, so that we had a very full agenda. And I can remember very clearly the very day on which I first encountered this issue. It was on the second day of my ministry. Some 15 heads of my department, 15 heads of the various parts of the health department came across to brief me on all the issues they'd prepared for the government. They all wanted to show off how much they knew the Labor platform and how they had answers to all the particular problems we faced.
Plus ça change.
and they brought, I remember, 2 great fat folders in which we went through these issues. It was a day-long meeting, and somewhere in the afternoon, I think at issue number 32, there was something called GRID. And I said, what's GRID? And they explained to me that it stood for gay-related immune deficiency. It was a disease which had been identified by the CDC in the United States, characterized by symptoms such as an unusual cancer and various unusual pneumonias. And I said, well, do we know anything much more about it? And they said, no, there are lots of theories. It might be a virus. It might be some form of bacteria. The tendency is to think it has something to do with the lifestyle of the people, because all of the people to date identified as affected were gays. And but they told me I needn't worry. They didn't think it was going to be a serious problem in Australia.
Plus ça change.
And because at that stage, even though we'd had 1 case reported, it hadn't been reported to Canberra. The communications between the state health departments and the Commonwealth Health were not very good, and so we didn't even know that we'd had.
And so this wasn't a reportable disease at this point?
It would not, I think, have been a reportable disease at that stage, no. But one would have thought that this unusual disease in New South Wales would have been, at least the message would have been passed on to Canberra.
So you must have been feeling really comfortable. You had the AMA taking you on, Bruce Shepherd was rising as your nemesis, and this was emerging as a major issue which was not going to be handled by the community very well.
Well, hardly my nemesis, Bruce Shepherd. He never really got me, but he caused it. He did cause...
He tried hard.
He did cause a lot of trouble. No, and I've got to say that to begin with, this disease was not very high on my agenda. There were lots of other pressing things. Prime Minister had insisted that Medicare be brought in within the year because he wanted to use it as part of his bargain with the trade union movement, the Accord. So we're under enormous pressure to get that in place. The pharmaceutical benefits scheme had created lots of problems which we had to cure. So I've got to say that AIDS was not at the top of the agenda in early 1983.
And the price of AIDS drugs, HIV drugs, was yet to emerge sometime in the future, probably beyond after your time.
Really, they hit my successor rather than me, yes.
There are some small blessings. David Menadue, how much fear was there in the community just as the awareness was that this was something that could break upon our shores and potentially devastate the community to which you belonged?
I don't think it was very visible in 82, 83, unless you're reading Adam Carr's articles, and I was, because I knew Adam from Gay Lib days. I knew he was a pretty responsible reporter, and I knew he'd done his research and learnt up on immunology. I didn't know I was HIV positive, and I went to a meeting at the dental hospital in 83, which a lot of gay community turned up to. So it was an item of concern. I'm not saying it wasn't. But I think people may have got the message from the panel sitting at that particular evening that it was really largely in the States that this problem was occurring, and that it possibly wasn't in Australia at that stage. I think there were warning messages. But I got the message that night that I shouldn't travel to America, which I was planning to do later. in the year, and I'm not sure how they thought you could catch it from hotel walls or what. I mean, there wasn't a firm view, although the concept of a virus was brought up at the night. So when you say fear, I think it was there in the back of people's minds, but until we started seeing people getting sick, I don't think it was quite the same.
David Paynter?
In fact, on the 5th of May, Weekend Australian ran a 2-page article about a new Black Death which was about to sweep the world, which had no treatment, and that this was going to cause havoc.
I'm glad to see the Australian hasn't changed in all those years.
Well, the reality was there was great fear about this in the community. For the first time, here was an epidemic for which medicine had no answer. And unfortunately, its identification with the gay community meant there was huge danger of prejudice and even physical assault on gay men and so on. And that stirred up all of those emotions, and by that time, the first Australian cases were being identified.
Gino, was there any sense in those days that this was something that would affect people who inject drugs?
Oh yes, without a doubt, right from the start, from the CDC's first study, which was well reported at the start of 1983.
Gino?
We swapped badge earlier, that's why Dave was answering for you. But in those early days, no, I remember Alex addressing us I worked for Alex at St Vincent's Hospital, and he addressed us in the mid-80s there and said that this was a problem we were going to have to face working in the King's Cross area, and there was a concern that we weren't doing enough, we weren't doing anything at all in an area of high injecting drug use, and there are some people in the audience today who took, I think, a courageous step of forming active groups of consumers and sex workers and drug users banding together to actually raise that issue more. And when we talk about courage in this area, I think that I always had the view then that if people are engaged in injecting drug use are facing these sorts of problems, and the backlash they're going to face from the community by identifying themselves as injecting drug users can come forward and say we need to do something about this, then as health professionals we need to stand by them and actually support them in that as well. So it was an area that was becoming more and more of an issue for anybody who worked within drug and alcohol area and health services in King's Cross, and no doubt in similar areas around Australia.
You'll all be ready now to start tweeting your comments, and when you do, if you could use the hashtag UOMWitness, which is up there, and we will take some of your comments as we go through. So this is the context, and now begins the period of conflict and confusion.
Health Minister Brian Austin and senior health officials revealed the tragedy this afternoon. The 3 babies had been given transfusion at Brisbane's Mater Hospital in February, and they died in September and October, 2 at the Mater and 1 at the Royal Brisbane Hospital.
Any men that have had in any way any homosexual experience, please do not donate blood.
One criterion above all others should be brought to bear on judging all legislative actions in relation to AIDS. Not whether it will or will not calm the hysterical. Not whether it will or will not infringe civil liberties. Not whether it will or will not make the government popular. The one criterion above all others is whether it will or will not impede the spread of the disease, whether it be productive or counterproductive in containing the dissemination of the virus.
The Brisbane babies. Now, Neil Blewett, Chris Puplik, we were at the launch of the Kirby Institute the other day. Chris Puplik, who was a Liberal senator at that time, had worked in the office of Peter Boehm, who had previously been the health minister under the Fraser government, as our Minister for Aboriginal Affairs. He told me that for him was the seminal moment when you called together a cross-party room meeting after the Brisbane babies, and you brought the man who donated the blood into the room.
Well, that was the moment of crisis, undoubtedly, in November 1984. As David had said, there had been quite a bit of sensational publicity in the first 18 months of the government, when we were in government. But it was all fairly, it was often sensational, and one had to try and calm things down. I thought David Pennington did a very good job in just trying to ease this sensationalist media messages. But the real political crisis, the real occasion which we had to face the problem in a much more public way, was with the case of the Queensland babies. And that is when we called together all the health ministers in the country, yes, just the health ministers, I think at that stage, maybe the premiers later on, but called them together to work on a national response to this disease. And most of the policies that we pursued began to flow out of that meeting. In fact, David's task force, he'd been a subcommittee of the NHMRC, but we turned him into the meeting, not me, the meeting turned him into the head of the National Task Force on AIDS. We also created NACAIDS at that stage, which was to look at the social...
But that came later.
Yeah. No, well...
Right, at the same time, the National Advisory Committee on AIDS, that was Ita Buttros's.
Yeah.
She chaired that committee. But let me... just talk to me about that parliamentary meeting. Because Chris Puplik had tears in his eyes when he was telling me about it just 3 days ago in Sydney, where you actually brought the guy who gave... Chris's memory is that you brought the guy who actually donated the blood into the room.
No, I do not remember that. I know that the young man who had... he'd been a regular donor, very, very loyal donor to the blood bank, and he was identified because blood could be traced, and he was subject to appalling attacks. Some of it understandable, I suppose. The father of one of the babies told him that he should commit suicide, and this was a public announcement. He was, as I say, subjected to quite, I thought, appalling criticism. There's a period of confusion between 1983 and this period in 1984 as to exactly what message we should be delivering through the blood banks and to blood donors. And I think the phrase we'd used was multiple partners. And this young man had not had multiple partners, but he still, of course, got the disease and passed it on to the blood transfusion.
How were you managing the politics of this, both within your own party and cross-party? Because you had trouble with Joe Bjelke-Petersen, but that's in another jurisdiction. But just managing the politics in the national parliament, because there certainly wasn't unanimity at cabinet level. I mean, my understanding is that Mick Young and Bob Hawke wanted to have a drugs war, just like Reagan, and they had to be talked out of it.
Well, I'm not aware of that. There were some hardline people. I'm not sure I can identify them at this stage. But you've got to remember that until the crisis with the babies, it was not a central political issue. What we'd been mostly doing in the previous 12, 15 months was sort of calming sensational media statements. I mean, for instance, the Medical Journal of Australia produced in, I think, June 1983 with a front cover, "The Gay Plague, the Black Death has come," and I think the Grim Reaper was featured there all over the front. It was my first public intervention, and I remember chiding the editor and saying, well, the mass media might be doing this, but the Medical Journal of Australia shouldn't be doing this. And he wrote back quite apologetically and said, look, I was only being ironic. And as we all know in politics, irony is a dangerous thing, isn't it? So you've got to get the context. We were worried about blood problems and trying to work out a solution there, but it was not a major political issue for the parties until you had this problem with the babies.
So how did you stop it falling apart politically?
Well, one of the ways was that none of the states were that keen on playing the key central role. That is, if the federal government was prepared to take up the task, I mean, diseases belong to the states, basically. The federal government in the past certainly hadn't been much involved in diseases as such. They were state responsibilities. But as one of my state ministerial colleagues said to me, look, Blewett, there's not many votes in prozzies, druggies and boofters. We're quite happy to pass it over to you. So that meant that it was possible to establish a national program much more easily than on most occasions when you had to try to bring the Commonwealth and the states together. Not every state, as you've mentioned, Bjorky Peterson, and also Tasmania. But Tasmania had a very low load in terms of cases, so Queensland was the problem. But all the other ministers, and they were also all Labor ministers that helped, enabled us to get a coherent national policy beginning to be developed in late 1984.
So, David Pennington, how clear was it to you what needed to happen now in terms of the blood transfusion service, a service which you had been intimately involved with most of your career, either here or in the UK?
Well, firstly, just one thing that we're in danger of overlooking. Neil was informed about all of these happenings with the babies in a period just 2 to 3 weeks before the federal election. And he was busy campaigning in South Australia when the telephone calls went through to him, and his chief of staff, Bill Botel, who's here, was trying to pull things together. And that AIDS conference involving all of the states occurred just 2 weeks before the federal election. The parliamentary issues, really most of those happened following the election. So we had, in fact, detailed plans. By that time, the virus had been identified. Ian Gust at Fairfield had, in fact, already gained access to enough antigen to be able to set up the testing for the virus. We found in September of that year that there had been transmission of the virus into the plasma used to produce factor VIII to treat haemophilia, and that there were still positive donations coming through the system. So we were concerned to set up a process to test the blood transfusion service with the virus that was developed by Ian Gust as a national program, and all of that was in place. We had, in fact...
And we were the first in the world to have that testing program in place for the blood service, for the blood supply.
Well, we'd been to Canberra just 2 days before the federal conference, and in fact discussed with the senior public health officer that Ian would need $300,000 to set up a national testing program involving every city in Australia. And that was then produced at this summit meeting, and $300,000 was just approved like that with a wave of hands. And Ian then went on and developed all of those programs. And that was absolutely critical.
So, Adam Carr, the Brisbane Babies episode created huge issues for the gay community, did it not?
It was the main point at which the blame game in the media, if you like, became intensely politicised, because, as you've said, all this happened in the middle of a federal election campaign, and some politicians were keen to make easy political capital out of it, and it obviously produced a reaction in the gay community. It was the event that led directly to a mass meeting in Melbourne, which formed the Victorian AIDS Council, at which people, by that stage, by 83, 84, people were obviously aware that this was a medical issue that was affecting us very badly. But it was the Brisbane Babies turned it into a political crisis for our community as well.
But David Menadue also raised issues about testing. Who was to be tested, whether it should be mass testing, whether it should be compulsory.
That was later. That was the following year.
David Menadue remembers it differently.
It was tested in 1984. Absolutely. Yeah,
the testing with the Ian Gust's model began at the end of 1984, ahead of the AIDS crisis meeting that Neil was referring to, and that showed that there was contamination through the blood service, and things had to move, and we planned the national testing, and Neil, following the conference, facilitated discussions with the American producers of the kits which were being developed, and we then worked with the American Food and Drug Administration to test the kits once they came, and those kits then became available in April 85, and at that time we then first tested every single blood donation in Australia from that date, and at the same time set up testing facilities in the community so that people could go and be tested voluntarily in confidence with associated counselling, and those tests were then all subject to rigorous review to be sure there were no false positives and so on.
Judy Freck, there was enormous pressure from the medical community, was there not, that there should be compulsory testing, that they weren't going to treat people unless they were tested?
I was a nurse, an enrolled nurse at the time at Fairfield, and we were just getting on with the job of looking after people that were coming into the hospital with GRID. And I don't actually remember, wasn't really involved in all this stuff, but it certainly, those Queensland babies changed what was happening, because Fairfield was by then associated with people with a disease that you caught if you were gay, and the backlash was, even for us that worked there, if people found out you worked there, would step away from you and say, how can you look after those people? And I know one of the girls that was there was taking someone on a escort during that time, and the taxi driver, because he picked them up from Fairfield, said, you're going to all burn in hell, including the nurses. So I think that's what the Queensland babies kind of changed. It made the public very much aware, they thought, of the sensationalising of the disease.
I'd like to bring in Bill Bortell. If somebody could get him a microphone would be good.
Yes, sure. If I might just say one thing about this Queensland babies thing for the record. And David's point about it being before the federal election is a very vital point. Those babies weren't all infected on one day and found out on one day by this donor. That happened over a period of weeks or months. And those babies, the fact of those infections was stacked up by the Queensland government to use in a political context, quite deliberately. It wasn't just one of those things. It was to be used in the way that it was to make a very big political statement against the federal government in general, and Neil in particular, and to create, which it did, a very big crisis. But it was done with malice aforethought. It was a very cynical bit of bastardry out of that government, which I, for one, never forgot or forgave. I was very glad in the history of it to see that Brian Austin eventually went to jail for his corruption. Unfortunately, not for his part in this other episode. That having been said, there was a lot of back channeling, and I just want to say for the younger people in the audience, one of the really difficult things at that time was the height of technological sophistication was that all the phones you could, had punch dials.
I was going to say, just spot the computer in the videos that you're about to see.
Yeah, it had to be done by fax. I think Neil referred to a letter. Things were done by letters. Faxes. You had to find people at home or in their office
we'll
on a landline.
We'll have a competition for those of you under 30 as to what a fax is, but we'll just...
Yeah. So just accumulating the information from people like Phil Carswell is here, or Adam, David, it took an enormous amount of time and effort during all day and evening to just find out what was happening in the various state capitals and around the country, and to talk to people like David or Ita or so on. It was a difficult thing to accumulate that information, much less than having to deal with people like Jonathan Mann in WHO, which was all done by fax and over a 24-hour cycle. So there was an enormous amount of talking, and I think what we tried to do in the office was to become at least a repository or a central clearinghouse, and then the department upgraded its effort so that they were there and working really well. But just to keep on track of what was going on was extremely, it was a very full-time operation.
So how much was done on the fly and how much was deliberate and opportunistic? So, for example, you directed funding through, for example, when governments wouldn't take your money, you directed it through the Sisters of Charity of all organisations. Sisters of Mercy, sorry.
Yeah.
Sisters of Charity weren't so charitable, were they?
The funding question is very important. Thanks to to Neil, of course, and the department. In those early years, a lot of funding was taken from here, there and everywhere. There was no new money basically funding the AIDS effort. So bits and pieces could be found for the 300,000 and so on, and was. But it became apparent as 85, 6, 7 came along that it had to be put on some sort of permanent funding basis. Otherwise, the prospect was that if there were change of government, or let alone a change of minister, that some of these understandings would just evaporate and the funding would go with it, and you couldn't trust the states, particularly to pick up the slack. So this was a very important question.
So, Alex and Gino, you're watching this happening and the maelstrom around the gay community with this, but you're also aware that there were growing HIV epidemics amongst IV drug users, particularly, say, places like the South Bronx. So you must have been watching that with some concern.
Yes, I was really... Well, my first encounter with AIDS was actually in the 1970s in London when we met a gay man from New York who was visiting London in late 77, and then he got sick over the following years, and his friends kept in contact with me. So, and he died even before June the 5th, 1981. But then I became, when we moved back to Sydney in middle of 1982, I was aware of growing information, and it was an evolving process. It was very, very confusing, but as time went on, things that seemed possible were then classified as probable, and then they became certain. So all the things we're talking about were very cloudy initially, and there were several events in 1985 that really stood out. And one of the events was the so-called Drug Summit on April the 2nd, 1985, officially called the Special Premiers Conference, which I believe was the first time the premiers met with the Prime Minister since World War II to discuss anything other than finances. And that was born out of the Prime Minister's daughter's, the public knowledge that the daughter of the Prime Minister had a heroin problem. And that was really critical because at that meeting there was a national commitment to an official drug policy of harm minimisation.
Which didn't come easily.
Sorry?
It didn't come easily.
It did come into it.
No, but it didn't come easily. I mean, in other words, it wasn't a foregone conclusion that that would be the outcome.
My understanding is that the document was prepared within the Commonwealth Department of Health and sailed through the Commonwealth Department of Health, and that day there wasn't really a lot of dispute on the Special Premiers Conference. It's important to realise and not sufficiently emphasise that at that time Australia had 8 governments. ACT wasn't self-governing. And of the 8 governments, 3 were non-Labor. So there was Bjelke-Petersen in Queensland, Tuxworth, Robin Gray in Tasmania, and Tuxworth in Northern Territory. And yet the 8 governments happily signed up to harm minimisation, and that's very important historically. But so that meeting, setting the tone of harm minimisation was important. And then in the spring of 1985, Jim Curran's visit from...
My memory is completely different. You were a drug warrior, Alex, at one point. I made a program that the drug war has failed, and you were my drug warrior, and that wasn't too long before this. And yes. And there was a very strong move. I've heard stories of Mick Young sitting on the floor of, and it's going to Ernie, whatever his name is, the drug czar in New York, and being talked out of a drug war in Australia. I mean, it was not a foregone conclusion that harm minimisation would be an outcome here. There were a lot of people who wanted to follow Ronald Reagan.
Well, I certainly wanted to have a needle syringe program established. It was originally called the Drug Offensive for marketing purposes, but harm minimisation was the official national drug policy. And when Jim Curran came to Australia in the spring of '85, he privately, didn't say this publicly, privately gave a lot of warnings to a lot of people. Don't mess the injecting epidemic in Australia like we have in the United States. And that message was heard loud and clear.
Neil, and then Gino.
I'll just comment on this. If you look at the communique issued by the Prime Minister and the Premiers, there is no mention in that short 2-page document of harm minimisation. If you look at the strategy document published, I think 3 days later by the Commonwealth Department of Health, with the agreement of most of the health departments, the very first sentence says the commitment to harm minimisation. And this, I think, reflects the fact that the health people, both at the Commonwealth and state level, were pushing for harm minimisation. The Premiers, Prime Ministers, hadn't been sort of tough enough to oppose that, but they weren't quite prepared to endorse it, so that you had a certain tension between the policies that developed. And in fact, I would describe what we had in Australia as a drug problem of prohibition with harm minimisation within a prohibition framework. And that was the kind of uneasy compromise that characterised our drug policy. And that was very important for AIDS because it brought in us expansion of methadone programs to try and reduce heroin injection.
Which Joe Bjelke-Petersen was in favour of.
Pardon?
Which Bjelke-Petersen was in favour
but Bjelke-Petersen was prey to sort of strange gurus. I mean, he'd get influenced by somebody who'd give him a brand new spanking idea and which he caught on to and then often implemented. And he'd been got at by somebody who was a very strong advocate for methadone. So that one of the reasons we were able to get the methadone passage to the Premier's Conference was because we had the Bjelke-Petersen on side who've usually been opposed to most of these proposals.
And this brings up a whole issue about how to communicate about the epidemic and how to learn about it.
Head of the AIDS Task Force, Professor David Pennington, says there's absolutely no danger to passengers following the death of a Qantas steward from AIDS.
We've got to get to the point of dealing with it responsibly, having responsible reporting from the media, looking at the facts. It is not a disease which will spread throughout the community. It is not a disease that requires people to be treated as pariahs and segregated and kept away from schools or kept away from normal employment.
This is cold comfort for most health professionals who've had difficulty in disseminating information to at-risk groups. One survey has suggested that 75% of doctors are unsympathetic to homosexuals and AIDS sufferers. The answer for some is bold and creative advertising to counteract the public hysteria surrounding the disease.
This is what triggered the gay community's fury, a strongly worded telex from the AIDS Task Force, warning of the inevitability of the spread of the disease to the general public and predicting that at least 60, possibly 100 Australians will die from the disease this year. The result was front-page stories, described by gays today as alarmist and unnecessary.
Adam Carr, no doubt you had a small part to play in that.
Yes. That episode brought to a head for us the conflict between our community-based response and some of the responses that were coming from the official bodies that had been appointed to advise Australian governments. At this point, when AIDS was a completely new disease, those of us in the gay community, in the media, who were reading medical press, reading the same articles that Professor Pennington and others were reading, the basis of knowledge from which we were all working was effectively the same. And we believed that the figures in that communique from the task force were wrong. I said at the time they were wrong. And history has shown that they were wrong. That the level of panic that was generated about the extent to which the virus had spread in the community, about the predictions about how many people had AIDS or were going to develop AIDS, created a quite unnecessary level of fear and anxiety in the community, which then created some of the political backlash that impeded the work that everybody was trying to do to tackle the disease. The federal government had set up the task force to provide medical advice to Australian governments, and it had quite deliberately set up NACAIDS, headed by Ita Buttrose, to try and handle the public relations aspects of reassuring the Australian community about the level of threat that really existed. And when communications like that from the task force entered into the public debate, the consequences were very unfortunate and quite predictable, quite predictably harmful. And I said at the time that the task force should not be making public statements of that kind, that should be left to NACAIDS, to people who had experience and skill in communicating these matters to the public. And I think history shows, what happened as a consequence of those episodes shows, that was correct.
David Pennington, let's bring back fond memories.
Well, the AIDS Task Force had a commitment to speak to the public, to advise them about the facts as they were emerging. And the member of the task force who was in fact an epidemiologist, Julian Gold, was an employee of the Commonwealth Health Authorities, working in Sydney on secondment and running a clinic to deal with AIDS, a very important clinic. It was he who estimated the number of people that he believed had the infection.
Incorrect.
At that time, we didn't know how long the incubation period was between infection and the development of AIDS, and there were many uncertainties at the time, but they were Julian's figures that were used in that release. But as far as we were concerned, we reckoned it was a disease that had to be taken seriously, and there was a very real need for government to be aware that they had to act to support appropriate strategies.
So your view, those releases were aimed at government as much as the community?
Oh, very much so.
I was unhappy about the way it was released. I'm all in favour of providing information to the public, but this was information of so dramatic a nature that it was my view that it should have been talked through much more carefully, and at least the minister should have been informed.
David Menadue, your response at that time?
I think it was HTLV3, that's where the confusion came in, that I found out in November 84. And it was the babies and the blood bank crisis that particularly started me to feel that I could be an object of attack. And I think that election was terribly damaging to gay men and people with HIV because we all felt, isolated. And the problem with being a person with HIV then was you were so afraid to come out. There weren't support groups. The AIDS Council had done their establishment work, and that was particularly to look after people with HIV and, as Adam said, to do that public relations, media work, education for the gay community. But for someone like myself, it put me into my shell. I felt very unsure who to turn to for support, even though I had people like Adam and Phil Carswell, who's there, the first president of VAC, who would tell you the latest and reassure you to some degree. My doctors didn't know what was going on either, because my doctor said to me, I think there's probably only a 1 in 10 chance you'll get AIDS illnesses because we think it's like hepatitis B. If you have antibodies, you might be protected from the virus. Well, of course, as the 80s unfolded, we found out that was not true. The antibodies didn't work. So, look, Norman, in answer to your question, I felt completely isolated and scared to know who to tell that I was positive.
And presumably scared out of your skin?
Scared. Well,
about your own prospects?
Well, for a little while I lived on that 1 in 10 chance and thought, I can live with 1 in 10 odds of getting sick. But then as the 80s unfolded and some of my friends started to get ill, I realised that, the chances of me not getting sick were small. So I helped set up a peer support group because the greatest strength I found in all this crisis was having peers that you could talk to about it and share your greatest fears. I mean, we used to sit in front of the Grim Reaper campaign and laugh because for us it was about black humour. That was the only way we could live with this kind of stigma that was being imposed upon us because, of course, I know I'm jumping probably, Norman, but in terms of the Grim Reaper campaign, for us that was about people hating or being worried about people with HIV and not so much the virus. And that level of stigma kept going on with nearly every report that was about, and I'm sure that 50,000 figure would have been, added to that stress.
One of the hallmarks for me around that time was the slow consolidation of an incredibly well-informed patient group. Although they never, to say that even now, some people's hackles will rise because the group, people never saw themselves as patients. They saw themselves as people living with HIV/AIDS. But nonetheless, you had a group of people who knew more than the doctors, who told the doctors what they expected and what they wanted, and eventually started dictating how research was going to take place. I mean, this was health consumerism that the medical profession had never seen before.
Yes, initially I don't think it was led by people with HIV themselves, although there were certainly people with HIV working in the various AIDS councils that have been established, but a lot of people didn't come out, not until 1988 with the Hobart Conference when all those people with HIV stood on the stage, and people were shocked because a lot of their colleagues were there and they had no idea they were HIV positive until that time. That's when the people living with HIV/AIDS movement, as you called it, because before we were all people with AIDS. None of us were people with HIV. We're all people with AIDS. And that's when a political consciousness developed in people with HIV, and I think what you're talking about in terms of demanding representation on ministerial advisory committees, being part of the response started. I think before that we were relying on people like Adam and Phil, and in ACON and other places it was the various spokespeople from those AIDS councils.
They begun from 83, 84 to play that role, and out of this developed a much more specific role with people with the disease. But I think it's important to note that from early 85, governments were funding the AIDS councils to prepare literature, to prepare education programs, so that already the task of, if you like, supplementing what doctors were doing was already in hand.
Gino, come back to the people who inject drugs and that community, a supremely marginalised and stigmatised community. In many ways, what you were involved with was almost an act of civil disobedience, was getting the needle exchange programs going with Alex.
Yeah, though my argument is always that Alex told me he had legal approval to do it when he asked me to do it. So. But
I was ordered to do it.
I was ordered to do it. No, not quite. But and with Kate Dolan, and Alex, we set up that first needle exchange. But some of the stuff you played and some of the results about GPs and having problems with dealing with gay patients and the like. Imagine from an injecting drug user point of view, they were rarely engaged with the health system. And the prevailing wisdom at the time in drug and alcohol was that unless someone was prepared to stop using drugs, had hit a rock bottom, as they called it, there was no point in even engaging with people who were using drugs. So they were turned away from services unless they actually displayed a commitment that they wanted to do something about their drug use. So we had this whole population out there, subgroup of people who were just getting access to nothing, no information at times and no services unless they were prepared to say, we're going to stop. And that's where, when Alex is talking about harm minimisation, I remember that debate at that time, and I wondered sometimes whether they even knew what they were signing up for. That's how it may have got through so quickly. But thankfully it did.
What were they in fact signing, well, not necessarily signed up for, but just give us a flavour of what you did in those early days to get this going, particularly in New South Wales?
Well, when Alex had decided to do it, and basically I think Kate sprang up the first $50 to actually buy the first box of syringes, and
Kate Dolan
had set up
the National Drug and Alcohol Research Centre,
to actually buy the first box of syringes. And then we just set up I don't think we get approval to do it anyway, so we just did in the hallway at the front door of the Drug and Alcohol Service, and we met with there were people like Julie Bates and Alan Winchester and the like, and drug using community, to try and get the word out there that it was safe to come to this service, because it was running so much against what they had been told and against what the previous experience had been with health services, that it was okay to come, say you're a drug user, get needles. If you had some others to bring dirty ones, that was fine. Even though it was an exchange, we'd still give you needles anyway. And we'd engage with people.
Was it technically illegal?
Yes, it was. I mean, Alex would probably confirm he had the meetings with the police at the time.
Breached the New South Wales Drugs and Misuse Trafficking Act 1985. That was the act that it breached. There's another step that should be mentioned in this history, and that is that in 85, 86, David Cooper and I and some others did a study of about 100 people in drug treatment in Sydney, and we had the new HIV test, and we tested them all, and there were only one or maybe two that were positive in that group. But one of the people who was positive, we tested 7 of his sexual and needle partners, and 4 of those 7 were positive. And that really terrified me. And I don't use the word terrify lightly. I really lay awake at night terrified about what could happen, that this epidemic could, bad enough as it was among men who have sex with men, I could see a cascade of infections going from men who have sex with men to injecting drug users out to the general community. And I knew we didn't have time on our side. We had to do something quickly. Sometime later, Grace Atwell, then working for the New South Wales Department of Health, was asked to clean some cupboards out in the Department of Health, and he came across 13 submissions which I'd written, begging to be asked to start a pilot needle syringe program, and either ignored or rejected.
And the health department was waiting for you to fail, wasn't it? Waiting for you to trip up.
Well, there were two critical people. The first two people employed as government officials working full-time in AIDS were dead against having any activity of this kind, any needle syringe program, and they blocked every effort I made to get it to happen. And finally, on November the 12th, 86, I don't know why on that day, but on that day I decided we were never going to get official permission, and either we started it or it was never going to happen, or not happen in time. And so that's the event that Gino is referring to. So I called some staff together and I said we should do this, and I'd been keeping them briefed up to what was happening. So we all put some money together and we agreed that we would run this as a voluntary activity, and we put a note on the door that day. Nobody pressed the buzzer that day, but the next day they started pressing the buzzer, and they have every day ever since, and we now dispense 35 million needles and syringes around the country every year. And it's, I'm sure that starting early was one of the reasons that was so effective. It was the right thing to do, and we did it early. And
compared to New York City, where I think South Bronx had HIV levels amongst IV drug users equivalent to Zaire, and their only needle exchange was next to the police station somewhere in New York City.
Yes, and I was very affected by a sort of back-of-the-envelope epidemiology paper that Ernie Drucker had published.
Ernie Drucker, that's who I was trying to remember, with Mick Young.
And somehow I'd come across this paper, and Ernie had done a very crude modelling exercise where he'd estimated from the infection that was occurring in the Bronx how many secondary and tertiary and other infections would take place over 5, 10, 15 years, and what this would cost. And when I read that paper, I could see that my terror was justified, that this was all based on conservative assumptions. And indeed, we were right to be very worried about the situation. And partly it was the unknown. And Neil, I remember seeing Neil Blewett make a comment in a television interview at the time where he said that it was better to be something along the lines, better to be bold and take the risk of doing something that turned out to be wrong or unnecessary to stop the epidemic, rather than not do that thing and allow the epidemic to race on ahead.
I might come back to Bill Botel, because again, this was another opportunity for subterfuge and under the radar.
I was always very struck by the willingness of officials and ministers at all levels to say one thing and do another, often for the best reasons. Neville McCarthy, who used to run CSL when Neil was in Atlanta, and I think getting you correct me, the terminology, but the viral reagent, or I think the things that came back for the tests, was to how to get it back into Australia. And Neil said, well, we need a licence and issued by the minister. And Neil just said, just take it, smuggle it in. And there it was. And that's how it got here so quickly. But there had to be a lot of talking because the ministers for health, the officials, even in Queensland, where there were people of goodwill who wanted to get things done, or in New South Wales, there had to be a lot of talking and figuring out about how to take it through the resistance and the points of resistance that were so opposed to doing anything at all. In Australian terms, not because people hate things so much, but so much in Australian political life begins with the word no, it can't be done. Well, that's okay if you want to talk about something in the long term, but when you're dealing with a crisis, those words have to be yes, not no. They have to be yes, but, and see how to get things done, and often against legal impediments and cultural impediments. So a lot of that work was done, and I was very impressed with how many people came out of nowhere, really, and got behind this. And a lot of work was done by people who are unsung and sort of, but really got on with it and changed these policies and the facts on the ground.
And the mythical caravan in the wall in East Sydney?
The
caravan in East Sydney at the wall?
Yeah,
Lizzie, do you want to talk about that?
Here. Yep.
Which was round about that time, and again, under the radar. The media never covered it at all, I think.
Yes. So I was one of the first 3 nurses employed to open the Albion Street Centre. That was March 1985. And during that year, it was recognised that male sex workers were going to be a huge, that HIV would be a huge risk for male sex workers. And that no one was even, and transgender sex workers, and no one had even thought of that, let alone the female sex workers. And so Julian Gold got me to help set up with Jeffrey Jackson, who was employed specifically to start the AIDS outreach bus, which is what we called it back then. And before the bus arrived in February 86 and launched in the Mardi Gras of that year, we were working from the Albion Street Clinic car, and we were driving around to different male parlours around Darlinghurst and King's Cross, and we were working from the car at the wall. And in those days, we were only handing out...
Just explain to Victorians and those from overseas what the wall is.
Oh, I'm sorry. The wall is a section of Darlinghurst Road, a beautiful old stone wall that surrounded the TAFE, which was an old jail. And on the other side was Green Park, which is opposite St Vincent's Hospital. But it was a well-known area for where male sex workers would hang and get their trade. And prior to that, historically, it was just a known place for men who have sex with men to pick up joints. And then it became commercial, and then it became more drug using. Anyway, there's a whole history about the wall. But having said that, we were handing out lots of condoms and lots of information and trying to get people to come to Albion Street for testing. And
you were doing more than just handing out condoms, though, weren't you?
Well, we started from when Alex...
I mean, you were teaching male sex workers how to use condoms in innovative ways.
Oh, yes. So it was all the basic education about condom use. It was huge HIV prevention education. We were testing people on the street. We were delivering HIV positive results on the street and in parlours at the time. And then we were supporting these people to take care of themselves. And then after Alex started the needle exchange at St Vincent's, we very quickly thought, well, we need to be doing something on the bus, because not only were we working on the bus at the wall and down in Tranny Lane, as it was known, and at William Street and up at Fitzroy Gardens at the Cross, we were starting to see more people who were injecting, and we thought we need to get the needles out here. It's great that they can go to St V's and get them, but there has to be something mobile. And we were also visiting all these bars from the Cross, all the bars on Oxford Street, and we'd end up at the taxi club. And we used to do 10-hour shifts, and we'd end up at the taxi club till 6 a.m. And so we were illegally handing out needles, syringes back then, and risking getting arrested. And I have to say too, back then, this was really before mobile phones and before the police were really on our side. They thought we were insane doing what we were doing. And it wasn't until the AIDS bus was attacked by about 15 to 20 vigilantes who attacked us with crowbars and bricks and whatever, because they came to the wall to kill the boys who were spreading AIDS, that created the very first gay police liaison amongst the gay community, and that still exists today. And very quickly, obviously, after that, we had the police on our side and they supported us.
Thanks very much indeed.
Thank you.
A very important part of the oral history. So let's move on. It was foreshadowed in that last video to the medical response and treatment.
The National AIDS Reference Centre, based at Fairfield, will become the centre point for training and education of West Pacific health workers in the control of the lethal disease. It will also collate information about the disease's spread through the region. Dr Gus says the worldwide campaign won't bring any overnight solutions.
The Albion Street Clinic is testing 250 people each week, and that's expected to double next year. The clinic is open 16 hours a day. Not that the staff are complaining, they'd like to see every person in a high-risk group. A computer has just been installed and is about to be linked with the American Centre for Disease Control based in Atlanta. Next week, an AIDS hotline will open to the public. There are 3 other AIDS clinics in Sydney and 1 in Melbourne, but others will be established around Australia.
If the only response in this country was to put the view that's come from the American gay community that all that's necessary is to preach the safe sex gospel and that this will prevent further spread, we know for a fact that it will not be observed by everybody.
Our evidence that we have, and it's not scientific evidence, I acknowledge, is that the majority of gay men that we're able to reach have modified their behaviour.
Because I think the only way we're going to beat AIDS is by having a national program. And, you know, we need all the bodies. We need the scientific and medical input, we need the educational input of NACAIDS, and we need state involvement as well.
But let me say again, we've got to be very careful about overreacting, because we will not win our battle against this disease unless we also have the active cooperation of the bulk of the high-risk people.
So it's fair to say, Neil and David Pennington, that your relationship was a bit tense at times during that period.
Well, firstly, we needed to move to get the testing in place to protect the blood transfusion service and haemophiliac people, and also then to be able to deal with the epidemic as a viral disease, not as a social gay plague or whatever. And we then knew what could be done to destroy the virus if there was spilling of blood and things of that kind. And it was absolutely clear from all of the epidemiological evidence that the disease was not spread by simple social contact, which was still a widely held view in the community. And we had to get all of that in place. But as well as dealing with getting the testing in place, and that was a decision we took in September of 1994, before the AIDS summit, and it was facilitated by everything decided at the summit. But in that same meeting where we developed those plans, we said we also needed a clinical structure to handle the interface with the gay community, and that was to be based in Sydney. And that was a plan that then, after the end of 84, was further developed and led to the establishment of the centre, initially at the Albion Street Clinic in Sydney, for clinical research into AIDS, epidemiology, to have that handled.
What's now the Kirby Institute?
It's now the Kirby Institute, which has done marvellous work.
But, Neil, the AIDS task force was a jurisdictional task force reporting to the Straits as well as the Commonwealth, and somewhat hobbled by the politics. And ITA's committee, the National Advisory Committee, reported to you.
That is correct.
And your aim in this was?
Well, for instance, I had hoped on the task force that it might be possible to put some, say, a gay doctor or somebody with a gay background, but also scientific background. But this was clearly vetoed by Queensland, that we couldn't have that definition of the task force. So the task force was a pretty scientific body, and I felt the need to have a social public relations body, and that's why we established NACAIDS. But NACAIDS was not established through the health ministers because the same veto would have applied. It was essential that you have representative of haemophiliacs, of the gay community. We had puzzles about how we would get effective.
So how did they change policy?
Pardon?
How did the existence of that coherent group, or trying to get a coherent group together as an advisory committee, how did they change your policy or the policy of the nation in terms of HIV/AIDS, having that group?
I don't know whether they changed our policy. I mean, in many ways, they became an agent of the policy, but they gave us advice on how to publicise aspects of the disease. They were very supportive of the decision that we made in early 1985 that half the monies going to the states for AIDS had to be paid into community bodies for education, preventive work, publicity. So on that side, it played a major role. There were what I would call creative tensions between the two bodies, but I thought in many ways that was good for the community. Out of some of those arguments, new policies or new ideas developed.
David? I mean, I remember at the time...
I just have to correct one point Neil made. There was no opposition to the proposition put to me by Neil on the day of that conference that we needed to have a gay person within the task force, and that was in fact something that did happen, and it was a very able man from South Australia who was a clinical psychologist, who was gay, had been doing research, and was a very valuable member of our task force for a matter of several years thereafter.
David Menadue, when did it start to happen? I mean, there's a cohort now, and it developed in the 80s and 90s, but just give us a sense of the start, or if you noticed it, and I'll come to Adam in a moment, of both gay doctors, but also but general practitioners often, who gained an enormous amount of expertise in this, and were seen to be much more community and person-centred than the specialist centres.
Look, I think the virus fortunately attracted gay doctors and gay health workers, to be honest, and even eventually some of the people that worked in the health department were also gay men, and probably some lesbians as well. So yes, I think the role of people with, the medical professionals, for me started way back in 84 when I got diagnosed, and I was fortunate to have a gay doctor and a couple of gay counsellors who I went to after I discovered I was positive, and that was at the Communicable Diseases Centre, which was in Little La Trobe Street, I think, in Melbourne then. But they started educating the broader GP community about, what to look for. So I would say it started quite early. And I think then, I can't remember when ASHM developed, but the concept of a national response amongst GPs was developing, I'm sure, in the 80s.
Alex?
I think Australia's response, there's no question, we've heard a lot about this today, was immeasurably strengthened by having many gay men involved in the whole process, including the policy process. And I think it has to be put on the record that the same is also true for other groups at high risk. And the people who inject drugs and sex workers were very dedicated, very committed, worked very hard, and were very involved. I certainly got a lot of help. Couldn't have done what I did, whatever that was, without help of a lot of people who inject drugs. And they acted in many other forums. Julie Bates is in the audience, and Julie really deserves incredible credit for her contribution, as do many others, but Julie's here, and and there've been mention of a few other people, but
let's get a comment from Julie.
While Alex and Gino were opening the door, or door C, door A you went in to pick up your methadone, you came out of door B when you were dosed, and you knocked on door C to get your fits, and it just didn't quite gel with some of the dispensing staff. They felt that was a pretty, we're trying to get people on the straight and narrow, and you're giving them fits. What are you doing? But anyway, while that was happening, we're talking about harm reduction. The process of harm reduction was being put into action by the community, by the affected communities of people who injected drugs and sex workers. And I was one of the co-founders of an organisation called ADDIC, the AIDS Drug Information Collective. Alex gave us space in the Rankin Court Methadone Clinic where we would gather. Our membership was made up of doctors and people who are using drugs, people living with HIV, sex workers and the like. We came together, and gay men, and we came together as a major force to be reckoned with. We supported each other, and we were each vying for funding at that time to set up our own organisations, funding to go to ACON for gay men, funding to come to us, the Australian Prostitutes Collective, and funding to go to this group that was called ADDIC. Now, many years later, many submissions later, Alex talks about how those submissions were found in a bottom drawer in the Department of Health. But in 1985-86, the Australian Prostitutes Collective received its first grant, $120,000, matched state for federal dollars, and we set about continuing and expanding our reach or our outreach to brothels right across New South Wales. We were the first in the world. It's recognised as the first time in the world a bunch of whores was recognised, not just recognised by its government, but was also funded. So it was a very proud day. But it wasn't until 1989 that we were able to get funding for the drug-using organisation that went on to evolve, to be known as NUA, the New South Wales Users and AIDS Association, which I proudly today sit on the board. It is the longest-serving user organisation continuously funded in the world. So a lot of world firsts for us in Australia. I'm pretty proud to have been there. And 30 years later, still standing to tell the tale. Thanks.
Thanks, Julie. So in terms of, Judy Frecker, the medical response, you didn't have much available to you. Can you remember when AZT was mooted?
I remember AZT very vividly because alarms were going off 4 hourly, night and day, as people took the drug.
So you had to take it every 4 hours on a 24-hour basis?
And alarms would just go off all the time, people taking it, waking up. So you've got to remember too, they were really sick people that were still waking up every 4 hours because they were just fighters and wanted to live, and that's all we had. And the thing about doctors and patients too, I think we need to remember that when AIDS first came, no one knew what to do. We couldn't give anybody any hope of anything. They just came in the door, we knew they'd probably die. And luckily some people have survived, but so we had no hope, so they had to work with someone. And I think that's why doctors and the health, the world of health worked with people affected or infected with HIV because they had nothing else. And so if someone had an idea, you had to run with it if it made a bit of sense. And also about the needle exchange and things, people were giving out needles before they were legal. Nurses, the contact tracers in Victoria, like Beth and Tom, they used to give it, I've been told they used to give needles to dealers so that they would get to the injecting drug users. And I think nurses are very good at acting with what's in front of them, so they just respond and do what they can with what's right in front of them. Bugger bloody politics and all that sort of stuff. Just get on and do it. These are people that are dying and we needed to do something.
David Menadue, you would have been, you've one of the few people left alive who've been through the lot.
Yeah.
What was it like being on AZT?
Horrible, truly horrible. Apart from having to wake up so often, I was still in a full-time job, and I would have to go to the sick bay during recess and morning tea and lunchtime just to get the energy to get through the day. And before that I was perfectly well. The next minute I'm taking this thing that's stripping fat and muscle off my arms and legs, and I'm having blood transfusions, and I'm thinking, is this really the right thing to do? Now, to this day, I don't know whether it was or not. It might have had some antiviral property. It might have kept me here. But, of course, AZT, because it was so toxic, there became a really strong anti-AZT movement within the gay community. Don't take that drug. And unfortunately, it lasted for quite a long time, I would say as long as 10 years, where positive people just remembered AZT, remembered how sick people felt, and so they wouldn't take the better treatments when they came along.
And the thing was, AZT in those days when we were doing it for hourly were toxic doses compared to what was given then, but people just were fear of AZT because it made people so sick. But that's all they had.
That's all true, but the important thing about AZT was that it changed the debate about testing in the gay community. Yes. Because for the first 2 years after the test became available, as everyone will remember, we in Victoria opposed the clinical testing for people, for gay men specifically. I mean, what other risk groups did was, in our view, was their business. But we actively campaigned against people getting tested because, in our view, as David testified earlier, David Menadue testified earlier, a positive test result didn't lead to anything. It didn't lead to a treatment. All it did was leave people in a limbo of fear and doubt. What changed that equation was the advent of AZT. Although it later, of course, turned out to be a very unsatisfactory treatment, it nevertheless, having a positive test result, in our view, did then lead to positive things you could do. You could go on treatment. The other big change in that period, which David also referred to, was the change in our understanding of what HIV infection meant. It became clear in the course of, I think, 86, 87, that 100% of people who have HIV infection would eventually progress to an AIDS-defining illness in the absence of a treatment. And that obviously changed the balance of risk and benefit in terms of what people should do. And our opposition to testing was always conditional. We said in our public statements, and Phil Carswell, who's here, will remember, if the available treatment options change, then our advice will change, and it did. And we changed our advice, I think, towards the end of 87. That was when I personally decided to get tested because, in my view, the balance of risk and benefit between the undoubted negative aspects of a positive test result in terms of trauma and discrimination and all the other bad things that people faced was then offset by the possible benefits of being able to enter into treatment. Now, I think that was in some ways the turning point, that period with the advent of AZT, because then a whole new, and this also relates to the previous point we're making about the emergence of an activist population of people with HIV. It was large-scale testing as a result of the advent of AZT that led to the emergence of that group of very well-informed activist people with HIV, who then led the movement for drug approvals and all the various things that happened in the 1990s, and who took over from the first generation of AIDS activists who had set up the AIDS councils. The activism moved into the hands of people like ACT UP and people who were campaigning on drug approval and drug trial processes. So there was a very major turning point with the advent of AZT, although AZT itself turned out to be not a very satisfactory treatment for reasons David has said. It nevertheless changed the whole political parameters that the debate was happening in.
Now, we can't...
So I was just going to say, AZT gave people hope that we never had before.
Yeah,
That's
sure.
why
Yes.
they woke up every 4 hours, and it didn't matter where they were in the journey, they woke up every 4 hours because of the hope.
I just wanted to comment that in 86, once we had recommended the establishment of the unit in Sydney for clinical research and clinical trials and whatever, at the time the news of AZT having an effect on AIDS was the first opening of a glimmering of hope of effective treatment. And we dispatched David Cooper, who was to lead the Sydney group, together with Richard Doherty, put them on a plane to go to a meeting in Paris where the drug company producing AZT was holding a conference, and he came back with a guarantee that we could access AZT in Australia. And David himself says to me that this was the start of the development of treatment, which has been his career ever since. As all of the other things came, he was part of the international group that were looking at effective treatment, looking at every possibility. And that, in fact, has been a very important part of Australia's response.
And one of those people was Joop Lange, who died on MH17. We can't leave this discussion, this witness seminar about the early days of HIV/AIDS in Australia without talking about the Grim Reaper.
Government paid airtime for the Grim Reaper advertisement ended last Thursday, although some TV networks are continuing to run it as a free community service. Professor Pennington says while the scare tactics of the advertisement served a purpose, he's concerned it's caused widespread and unnecessary alarm.
large sections of the community believe that they're at risk where they're not.
It's also completely contradictory to our own interests. We don't want to divert attention from the fact that AIDS primarily affects gay men at the moment. We've been saying that for years because we desperately need assistance to cope with the epidemic in our own community.
It sounds like we're going to get a much more explicit message. Well, I think we do have to tackle some of the problems we've had in that area. For instance, as you're probably aware, one of our advertisements was in fact censored. We were not able to show, for instance, a homosexual couple in bed, and I think that probably weakened the message we were trying to put over.
So, Adam, wasn't your favourite ad?
No, we supported the concept of a national awareness campaign, but as I must say, I wasn't directly involved in this. I think Phil Carswell here was much more directly involved. But my understanding is, as the process went on, we had less and less input into what was going on. But
Phil, do you want to comment?
Yeah, I was on NACAIDS at the time, and there was a small group, and Bill was on it, and so was four other people. We never saw the ad until the night it aired. And I think we had a major problem with it because the opening sentence of the ad said, at first it was only homosexuals who got AIDS. And we found that dreadfully offensive in terms of our lives were dispensable, but now the rest of the communities are under threat. Therefore, somehow we now need to take it seriously. There's been a lot of revisionism about the Grim Reaper, and a lot of people, because everybody remembers it, everybody has their own take on what happened. You have to remember that at the time we had a very much aware gay community, but the rest of the community didn't think it was their problem. Straight after the Grim Reaper was aired, our phone lines and our requests for speakers and our requests for information went through the roof. So it actually opened doors, and I know there was a negative side effect in terms of people living with AIDS, but even by that stage, that wasn't a recognised group as such. It was more the gay community rather than people living with AIDS. Apart from that, if you put that aside, if you can...
So it activated people?
It made people aware that they needed to find out more. And that broadened our base of support and our base of community awareness. I got invited to talk to surf lifesavers, to schools, to go to Rotary clubs. We went and talked to people who would never have thought they had some sort of ownership or some sort of partnership in this whole epidemic before. They thought it was something that happened to other people, them over there. But then they suddenly realised it could be their son or daughter.
So here's my question, because the other day at the Kirby Institute, there was the opening of their new building, and I had Norman Fowler on the panel, Lord Fowler, who was the health secretary at exactly the same time that Neil Blewett was health minister here. And he's just written a book called AIDS, Don't Die of Prejudice. And he argues that, and they had an equivalent Grim Reaper ad in the UK, which he still believes was the right thing to do. And he believes there should be more of it now because we've lost the momentum and HIV infection rates are going up again.
No, because the problem now is that AIDS is not a death sentence. And that's the fundamental shift that's taken place. We need new messages that are more carefully crafted, that talk about a whole range of other issues. Because back in those days, the greatest education we had was burying our friends. I mean, that reinforced the message so strongly and so vividly. You were talking about conflict before. We had people working on policy development on a daily basis. They then had to go home at night and hold the hands of people who were dying. That conflict was not only on a political level, it was also on a personal level and a grief level. That doesn't exist anymore, and thank God for that. Hooray. But there are still... So HIV is not a death sentence anymore, but it is a life sentence. And somehow or other we need to get a more subtle message across. And as an old health promoter, I know that fear campaigns don't have a long-lasting change of behaviour impact. But they do alert you to issues. But what we need now is a more sophisticated series of campaigns, but yes, more visible than what we've had up to now.
Including... Do you think, I mean, Norman Fowler's point was that to get to stigmatised and marginalised communities, it's extremely hard, and maybe you need community to be galvanised to do that.
One of our big problems we always had was that a lot of gay men didn't identify with the gay community. And it goes right back to what Bob Hawke said about gay men don't give blood. The next day, the blood bank had phone calls from all these men saying, my wife's gone and given blood, she doesn't know I'm bisexual. There are men who have sex with men who don't identify with the gay community, and you can't identify them, you can't see them, you can't pick them out of a crowd. So if we're going to do really effective community education, it has to be for the whole community. It can't. Specific populations do need particular information, but the only way people have to understand this is there is not somebody they don't know that isn't affected by this disease.
We've got a few moments, but just a few moments for comments from you, the audience, if you want to make them. So just come up to one of those microphones and we'll take your comment as we go. Neil, you copped a lot of flack for that ad.
Look, and I think David Pennington would agree with me, we hadn't handled the blood transfusion issue that well. I mean, we'd been uncertain about what messages we should put out. We were getting conflicting information from the United States about it. And so simply when the reports came out of the 1986 Paris conference that there was significant heterosexual transmission in Africa, then that information coming back to us, I thought we had to simply take a worst-case scenario in this instance, that we had to warn heterosexual population of the dangers. And that is the essential reason why we did that hard-hitting advertisement, to make sure that this time we gave a very clear message that there was heterosexual transmission. The African evidence, now that's been much debated, and the sort of the conditions, the medical conditions of African women and all those sorts of issues arise. But at the time, and you've got to remember we're responding to each new problem thrown up by the epidemic, we went down this path. The one criticism I would have of it, lots of other criticisms no doubt, the one I have, and this was brought home to me talking to people, is that it was very tough on those people who had the disease. Here there's the medieval figure of death, and I recognise that and I regret that.
And, sorry, David?
I agree entirely with Neil that we were learning as we went, as things evolved, and in fact the Grim Reaper message was entirely consistent with the global picture once we knew what was happening in Africa and elsewhere. And you've heard my comments at the time in respect of its relevance to Australia. But there is no doubt that it was a dramatic advertisement, that it did make the general population aware that here was a big problem that had to be dealt with. And I think it made it easier for government to allocate money in dealing with the many different problems. So I think in looking back, there's no doubt at all that it was a positive influence in the course of Australia's management of the disease.
Fiona Stanley and then Ian Anderson.
Thanks. Yes, I have two questions actually. One relates to the, I think, terrific response from the NHMRC and the people collecting the epidemiological data, the immunological research, the social and sexual research going on. And so you haven't mentioned that a lot, about how that research and data response to this epidemic happened and was coordinated. To me, I think that was incredibly positive. And what was the role of NHMRC and the specific HIV committees there? So that's one question. And the second question that no one's addressed really is the illegality of homosexuality. Because, you know, I can remember going to the West Australian government with the gay guys from there and the head of the CWA, would you believe, in her twin set and pearls, to convince the Labor government in Western Australia to legalise homosexuality so that we could legitimately do health education amongst a legal community. So that's something that hasn't been mentioned, and I wonder how important it was.
On the first one, which I probably won't get them to answer, but my first one challenge back to you, Fiona, is there's plenty of research and excellent data in the United States, but a very different response. So really, did it make any difference at all? Wasn't it just the community response and the social and political response rather than the research and data? Because, you know, the US had research and data coming out of its ears, but it responded in a very different way.
Well, that's a very good comment, but I think that, and I absolutely acknowledge that it was the community response that made the huge difference in Australia. But we also had a coordinated data and scientific response that it interacted, because of the way you'd set things up, interacted with the gay community and the drug abusing community and so on.
And Adam, on the second point about the...
Yeah, on the second point, I mean, this turned out to quite differently to how we originally expected. At the beginning, we thought this would be an absolute calamity for our community. It would result in us being stigmatised and quarantined and recriminalised and sent to isolation camps and all the rest of it. And that was one of the big motives for us to get organised at the beginning. In fact, it turned out to be quite different, because the public profile that the AIDS epidemic willy-nilly gave us, whether we wanted it or not, actually played out as a major positive for the image and position of the gay male community, and it contributed materially to legalisation in Western Australia and in New Zealand and eventually in Tasmania, and it actually changed the way a large number of Australians thought about homosexuality and gay men and the gay community in a very positive way.
Ian.
Okay, so I was just thinking that one of the things that we learned in this country very profoundly is that effective public health requires working with affected communities who need to lead change. I just want to make a couple of comments about the Aboriginal experience of the epidemic. For most of the 10 years during the history of the epidemic, Indigenous issues weren't particularly talked about. Aboriginal people weren't engaged in the epidemic, and there was a kind of an agreement around keeping the issue invisible. The things would happen, but they would happen under the radar. So there are very good Aboriginal health workers. I was an Aboriginal health worker when the epidemic first came to Australia, working in an Aboriginal health service here in Melbourne. There was a conversation about what this epidemic might mean to Indigenous Australia. And over the period of the first 10 years, there were a number of Aboriginal workers, gay men, workers in injecting drug use who started to take up the baton. But the invisibility cost lives. It cost lives because the prevention message wasn't getting out and people weren't getting access to the treatments and the support as it came on board. And it really wasn't until the mid-90s where we actually started to have a policy response for Indigenous Australia. But whilst we had a problem with invisibility, we also had a problem with visibility. And the problem with visibility is that there's already a very strong discourse about Aboriginal people which puts us in the licentious, sexually rapacious kind of part of the world. And so any time someone started to talk about Aboriginal HIV, it was always in the context of what they called the Black Holocaust. So Fred Hollows at the AIDS conference in Alice Springs talked about setting up quarantine for infected Aboriginal people with HIV. And so it took a long time to get the conversation happening. I chaired the first working party that looked at Indigenous sexual health. I must say it was one of the toughest jobs I've ever done in my life, and part of it was about finding a way to have sensible discourse. Part of it was about getting the Aboriginal leadership into a position where we could talk about it. Part of it was about getting the HIV/AIDS sector, as it was at this stage, and the Aboriginal sector actually stopped throwing rocks at each other, homophobia versus racism. And I think the third bit of it was trying to figure out what we knew we could learn from the history of the epidemic that we could actually learn for Aboriginal Australia, and also what we needed to do that was, from a public health point of view, quite different, particularly around untreated STDs, which by this time we knew was putting Indigenous Australia at considerable risk.
Thanks, Ian. And just two final and very brief comments, because we have people coming to this lower auditorium.
My name's Suzanne. I'm from the Disability Networking Zone in the Global Village. I'm both a healthcare worker but also been involved in the HIV community for very many years. Australia has shown wonderful leadership in the way it works with affected communities and how we prevent HIV through caring and not through punishment, but through stigmatisation or criminalisation. I want to say that even Australia is not there yet. We are still leaving people behind, and internationally, people with disabilities are also being left behind. People with disabilities number about 1 billion people, about 15% of the world's population, but what access do they have to information and services? You look at the levels of violence against women and girls with disabilities are much higher than their non-disabled peers. Where are their voices? Where is their experience? Why aren't we working in partnership with people with disabilities?
Thanks. I'll take that as a comment and an important one, but thank you for that. Yes?
Well, actually, our new national HIV strategy does not make any reference to people with disabilities. And I've worked at the Melbourne Sexual Health Centre where there is a deaf client. When he comes in, the person who interprets for him is the contact tracer. They don't want to risk hiring an external interpreter. Where does this man get support in the positive community? Where does this man get support in the deaf community?
David, do you want to comment or manage you?
Gosh. We have had support groups that have involved certainly people with various disabilities at the AIDS Council. Whether they're adequately handled, I don't know, but I'm certain that, we do care for people with a whole range of disabilities.
So I'll come to Judy.
I don't know about the deaf community, but I certainly know from the COLD communities that we work with and asylum seekers, they refuse to let us use interpreters because they don't want them to know that they're HIV positive because the stigma is still there, and it's still one of my clients was threatened by the community leaders. They were going to kill her because they found out she was positive when they read a letter that arrived. And one of the health workers I was working with said, why did they open her letter? They're not allowed to. Well, that's not the point. The point is that people are so frightened of disclosure even today that they can't use interpreters to help us give them better care. So we have to work around that. And we're all very good at charades, I think.
Yes.
Very sad.
And briefly, if you can.
Briefly, Roger Garcia is my name. I've been working in HIV since November 1984, initially with some epidemiological work related to haemophilia. I just wanted to make a comment really because many people will not have lived through that time, and also to make a comment about why those estimates about the impact that was going to potentially occur, why those estimates might have been as high as they were. Between November 1984 and May 1985, before that we really had freely available licensed tests, what were being used to test were the assays which were immunofluorescence and then subsequently Ian Gust's work down in Melbourne. So difficult was it even to get tested that to get my samples, the samples from my patients tested, I had to drive the samples down to Melbourne myself because a courier refused to transport them. That was January 1985. So by about March 1985, we had the results of those tests, which showed that 78% of those haemophiliac patients who had severe haemophilia had been infected. So this actually established, and it was known to government as a result of those sort of prevalence studies, that if there was enough exposure, this virus would not spare anyone. And at that stage, the medical community was uncertain whether some people were naturally protected against infection. Those sort of rates coming through gave everyone a pretty clear indication that there weren't going to be people genetically protected against HIV, and that fed into the epidemiological data and the predictions, which led to some of the figures which you saw. Clearly, if there's enough risk, then there's very high rates of infection, and the tragedies in many developing countries have borne testimony to that. The other thing I just wanted to say in closing is the epidemic in Australia would have been far worse had it not been for the people who are on the podium. And these people we've had the pleasure to hear explain their thinking are iconic and really deserve an enormous amount of applause for the contribution they made as individuals, and often at personal cost, to stamping out the rates of infection which we're predicted to have. Thank you.
So you're absolutely right, but hold the applause because it's going to come in a moment. Phil?
That actually segues quite nicely into what I was thinking about saying. And yeah, while I agree that the people on the podium, a number of whom are my personal heroes, I think we need to always remember that there were tens of thousands of heroes who did things every day. Gay men who changed their sexual behaviour, injecting drug users who stopped sharing, sex workers who insisted on condom use, people with haemophilia who had, in such a small community, suffered in such an enormous loss and grief. All of us who went through those years and came out different people. It wasn't, I mean, yes, we did need leaders, and leaders are important in any political situation, but the real truth and strength of the Australian response was the mass community response behind it. It wasn't just people yelling from the hilltops. It actually meant tens of thousands of people actively every day doing heroic things, including, I have to say, the people in support who held their hands and washed up the diarrhoea and cleaned up the vomit and then buried their friends. Those people are the real heroes, and I think that's the real narrative that we need to remember.
And I might just finally ask Alex Bodak and Neil Blewett the same question, which is, if it were to have happened in the political climate of today, would we have contained the epidemic?
I think that the bipartisan nature of the national policy would not have been possible today in the present conditions. The nature of political conflict at the moment, I think, would have made it not possible to pursue the policies we did, which we could only pursue, in a sense, because we did have, at the national level, basically bipartisan support. People like Peter Bone, Chris Pulplick, they kept the rabid National Party and other odds in line, so that there was never, John Howard was always supportive, and I just find it very difficult to see that situation being replicated today. But I want to say I thought it was one of the great assets that I'd been to the United States in 84, 85, and I had seen Christmas break, 84, 85, and I was appalled by the fact that AIDS in the United States had become simply a partisan debate between the Republican Party on one side and the Democrats on the other. And I think it was tremendously important for the work here that at the national level it was bipartisan. We had problems with Queensland, as I've noted before, but nationally it was a bipartisan policy which I think would be very difficult to sustain today. Though, let me say, it is possible if the nation faced another challenge like that, and I'm in a way heartened by the positive bipartisan response to the terrible tragedy in Ukraine on both sides, that perhaps when you do face a challenge like AIDS, then the chances of bipartisanship are better.
Alex?
Well, I'd like to refer to an intervention to support what Neil's saying, which occurred at the Hobart AIDS conference, which I remember very well, when the Honourable Wilson Tuckey, who was then the Shadow Health Minister, broke the spirit of the bipartisan spirit, albeit very briefly, and he spoke against the spirit of inclusiveness, which is really for me, the defining characteristic of Australia's response, that all the people most at risk should be sitting around the table where the decisions are made. He broke that spirit at the Hobart conference, and I think he continued to last in his position as Shadow Health Minister for 3 or 4 days. These days, if someone wanted to say that sort of thing, I think they wouldn't be in trouble about keeping their portfolio. One is the politics is different, this toxic relationship between the major parties, but also the media is so different now, and the media foments this toxic political relationship which thrives on short-termism and nothing else. And people were taking bold political risks, and we have to acknowledge that, on both sides of politics in the 1980s, and that's why the result went so well, because we were only going to get a good result if bold decisions were made in the public health interest. And those decisions, the wisdom of those decisions, we all know, everybody in this room knows full well how beneficial they were. Played over today for the first time, we wouldn't get that because of the politics and because of the media.
David?
A brief comment. I agree entirely with what Neil and Alex have said, but I just want to make the comment that the Prime Minister has been supportive of Australia having this AIDS conference, and I'm told we'll be here for the opening of the conference tonight. Years ago, a former Labor cabinet minister said to me, if you want to change what a minister is saying, he's got a right to say it if he's been elected, but if you change public opinion, then he will change because he wants to be re-elected. And as I've dealt with issues of illicit drugs and so on, I'm certainly strongly of the view that if we can mobilise public support, then if we can get the media to really look at the issues, not just for 10-second grabs, then I think we can mobilise political support for things that do have to be done.
Ladies and gentlemen, the people who saved us from the enormity of spread of HIV that many other countries saw who were similar to ours. The people who saved us from it are in this room. Some of them are on this panel. And as Phil and others have said, many hundreds, if not thousands, are not in this room. Could you please applaud them all?